Welcome to Clinical Horizon. This is the Stroke Master Course, a complete masterclass in 3 parts: acute ischemic stroke and the race to reperfusion, the etiologic workup and secondary prevention, and the hemorrhagic finale, based on Harrison's Principles of Internal Medicine, 22nd edition, with current guideline correlation.
When a large blood vessel in the brain is blocked, the brain loses approximately 1.9 million neurons every single minute.
Every single minute.
Like 1.9 million. We hear that phrase, time is brain, thrown around like a motivational poster in a hospital hallway.
Yeah, right next to the hand washing signs.
Exactly. But looking at this masterclass, it's not a slogan. It is a strictly measured, just relentless rate of destruction.
And that math, it dictates the entire physiology of the medical response. Our mission today is to kind of demystify how modern medicine actually fights back against that massive neuron loss.
So where do they even start?
Well, to understand the battle plan, you have to picture the brain tissue during an acute ischemic stroke, which is a blockage in 2 distinct zones.
Okay.
The first zone is the core. This is the localized area of brain tissue where the blood flow has dropped so low, like right at the site of the blockage, that it crosses the threshold of survival. It dies in minutes.
Wow. So nothing brings it back?
Nothing. It's permanently gone.
That's heavy.
Right. But surrounding that dead core is the second zone, and this is where the entire emergency room focuses its energy. It's called the penumbra.
The penumbra.
Yeah. Think of it as the surrounding ring of tissue that is silenced, like it's not functioning, which is why the patient actually has symptoms.
Blurred speech, paralysis, that kind of thing.
Exactly. But it's being kept barely alive by this trickling collateral blood flow from neighboring microscopic vessels.
So it's basically starving.
It is entirely starving. And the ER protocol is a desperate sprint to save that penumbra before it starves completely. Because if it does, it gets sucked into the dead core, which is expanding outward with every passing minute.
We are effectively talking about manipulating time and tissue here.
We really are.
And to see how we do that, there's this incredible real-world case study from the sources. It's a 62-year-old shopkeeper.
Oh, yes, the shopkeeper case.
Let me just paint the picture for you.
And
at 6:40 p.m., he's mid-sentence, and his right side suddenly goes completely dead.
A dense right hemiplegia.
Right. His speech slurs. But, like so many families do, they wait.
They think it might just be fatigue, or maybe he slept on it wrong.
Exactly. They try a quick home remedy, wait some more, and then finally they drive him to the hospital. He rolled through the casualty doors at 9:50 p.m.
Which is...
That is over 3 hours after the onset.
Yeah, that's a huge delay when you're losing 2 million neurons a minute.
Exactly. So he has this dense right-sided paralysis. His gaze is involuntarily pulling to the left, and he can't speak. Oh, and his blood pressure is sitting at this alarming 196/104.
Right. And when a patient like this hits the door, the modern parallel pipeline activates.
The parallel pipeline. How does that differ from just regular ER stuff?
Well, the traditional hospital runs sequentially. You do triage, then you wait for a bed, then a doctor evaluates you, then they draw blood, then you wait for the scanner.
Which takes forever.
Exactly. Sequential processing guarantees the death of the penumbra. So modern stroke units run everything in parallel. It functions honestly like a pit crew.
Oh, I like that analogy.
Yeah, at minute 0, the patient isn't sent to a bed. He is triaged directly onto the CT trolley.
Wow. Directly to the scanner.
Directly. While the wheels are actually rolling down the hallway, nurses are establishing IV access, checking finger prick blood sugar, estimating weight, drawing labs.
All at the same time.
All at once. The family is being interviewed for the exact time of symptom onset, literally while the patient is physically sliding into the scanner.
Now, the natural assumption here, and I definitely thought this, is that they're rushing him to the CT scanner to find the stroke, like to see the clot.
Right, which makes sense intuitively.
But the masterclass highlights this massive misconception that initial non-contrast CT scan is only asking one binary question.
One question: is there blood?
Right. Is there blood? A perfectly normal-looking CT scan in those first few hours is it's entirely expected when you're dealing with an ischemic stroke.
Exactly. The scan is not there to diagnose the clot. We already know he's having a stroke from the bedside exam. The paralysis, the gaze deviation.
Right, it's obvious.
The normal scan just confirms that his brain isn't actively bleeding. And the sole reason we need that confirmation in the first 10 minutes is to determine if we can safely inject the clot-busting drug into his veins.
The Tenecteplase.
Yes.
But wait, hold on. His pressure is 196/104. If you pump a powerful clot buster into someone with pressure that high, aren't you practically guaranteeing that those starved, fragile vessels will just blow out and bleed into the brain?
And that, right there, that is the exact reflex that causes delays in the ER. And it brings up a crucial distinction in how we handle medical exclusions.
Okay, so
The masterclass clarifies that high blood pressure in this scenario is an instruction, not an absolute refusal.
an obstruction.
Right. The firm threshold to safely give Tenecteplase is a pressure under 185 over 110. So rather than saying, oh, his pressure's too high, we can't give the drug.
They just fix the number.
Exactly. They treat the number immediately. They push IV labetalol while he is still in the scanner room.
That's fast.
Super fast. Labetalol works rapidly to block certain receptors, and it smoothly drops his pressure into the safe zone without, crashing his overall blood flow.
So because they viewed the pressure as a fixable hurdle,
Yeah.
they pushed the clot buster at exactly minute 38 of his arrival.
Which is incredible given he came in over 3 hours late.
Getting a clot buster in 38 minutes is a huge win. But based on his physical exam, the severe paralysis, the gaze deviation, the doctors knew a simple IV drug wouldn't be enough, right?
Right. They suspected a large vessel occlusion, a massive blockage in a main artery.
A big plug in the pipe.
Yeah. So they initiated a drip and ship protocol. While he was on the CT table, they followed up the non-contrast scan with a CT angiogram.
Okay, so that's where they use contrast dye to light up the blood vessel.
Exactly. And it confirmed a massive clot sitting in the M1 segment of his middle cerebral artery.
Oof.
Yeah. Big clots in large vessels, they often just laugh at IV thrombolytics.
Like the drug just washes over it.
Basically. The drug might chip away at the edges, but it won't dissolve the main plug. So they gave him the drug and immediately transferred him for a mechanical thrombectomy.
Where they go in and physically take it out.
Yes, it's fascinating. A neurointerventionist snakes a microcatheter from the groin or the wrist all the way up the body into the brain's arterial tree.
That is just wild to think about.
It's amazing. They deploy a stent retriever, which is essentially this tiny wire mesh that embeds itself into the clot.
Kind of like a stent, but they pull it back.
Exactly. They use powerful suction, and they pull the entire mass out of the body. They reopen the pipe mechanically.
And the shopkeeper's outcome proves the system works. I mean, he got the drug, he got the mechanical thrombectomy, and he walked out of the hospital on day 5 using just a stick.
With his speech rapidly returning.
It's incredible. They saved his penumbra.
They did. But, the master class makes a heavy pivot here.
Right.
Dr. Gaines states that the first stroke is an event. The second stroke is a verdict on the medical workup.
A verdict, meaning it's our fault if it happens again.
Basically, yeah. Surviving the ER is just step 1. If you discharge that patient and the file just says, hypertensive stroke, you have failed them.
Well, why is that a failure? Hypertension causes strokes, right?
It does, but it's a dangerous wastebasket term. It doesn't actually tell you how to prevent the next one. The medical field relies on the TOAST classification to put every stroke into a highly specific box based on its underlying mechanism.
Okay, so what are the boxes?
Well, was the plumbing blocked by large artery atherosclerosis, like a buildup of plaque in the neck? Or was it cardioembolic, meaning a clot formed in the heart and traveled up?
Oh, I see.
Or was it a small vessel lacunar stroke deep inside the brain tissue?
Because if you don't know the box, you don't know the weapon. You can't just hand everyone aspirin and hope for the best.
Absolutely not. The underlying mechanisms demand entirely different strategies. Like if you identify a symptomatic carotid artery blockage, a large artery problem in the neck,
Yeah.
the risk of a second massive stroke is heavily front-loaded in the first 2 weeks.
So time is a factor again.
Big time. And the primary treatment isn't just a pill regimen. That patient needs a vascular surgeon to physically clean out the artery within a fortnight.
Wow.
But conversely, if the TOAST classification points to a small vessel lacunar stroke, the primary intervention is militant, sustained blood pressure control to protect those tiny, fragile vessels.
So, returning to the shopkeeper, the team had to figure out his box. His initial 24-hour heart monitor, the standard Holter monitor, it showed a completely normal sinus rhythm.
Perfectly normal heartbeats.
Right. And if they had stopped there, he would have been labeled an undetermined mechanism. But they sent him home wearing an 11-day extended rhythm patch.
And that patch is the key.
It really is. On day 11, at 3:40 in the morning while he was sleeping, that patch recorded 40 minutes of completely silent atrial fibrillation.
Silent AFib. And finding that fundamentally changes his trajectory.
Oh, so?
Well, in atrial fibrillation, the upper chambers of the heart stop pumping effectively. They just quiver.
Just kind of vibrating.
Yeah. And when blood stops moving smoothly, it pools in the crevices of the heart, particularly the left atrial appendage, and it forms a large gelatinous clot. Yeah. And when the heart eventually beats normally again, it launches that massive clot straight up to the brain.
And standard antiplatelet drugs, like aspirin, they just don't work on that kind of clot, do they?
No, they don't. Aspirin prevents platelets from sticking together, which is great for plaque ruptures and arteries, right?
It is.
But it does virtually nothing to stop the coagulation cascade that forms those large pooling clots in a quivering heart.
Yeah.
Discharging an AFib stroke patient on just aspirin is arguably the single most preventable cause of a massive second stroke.
That's terrifying to think about.
It is. To stop those heart clots, he required a specific blood thinner, a DOAC, which fundamentally alters the blood's ability to form fibrin and actually clot.
So that 11-day patch was just as life-saving as the whole pit crew in the ER.
Oh, absolutely.
Now, this focus on the heart mechanism brings up a really fascinating caveat from the sources regarding younger demographics. They call it the Indian exception.
Yes, and it highlights a major blind spot in global medicine.
Tell me about it.
In many developing nations, particularly in India, a massive driver of strokes in younger patients is rheumatic heart disease.
Right, from childhood.
Yeah. A childhood strep throat infection triggers an autoimmune response that severely scars the mitral valve in the heart over time. This condition is called moderate to severe rheumatic mitral stenosis.
And if they have that scarred valve, you can't use the modern DOACs.
You cannot.
Why? I mean, if a DOAC is the gold standard for heart clots, why does it fail here?
It comes down to the physical dynamics of the blood flow. A scarred, tight mitral valve creates severe mechanical stasis.
Mechanical stasis, like a roadblock.
It's a literal physical bottleneck where blood churns violently. And this mechanical churning creates a totally different, way more aggressive type of coagulation environment than typical AFib.
Okay, so the DOACs just aren't strong enough.
Sort of. Modern DOACs are chemically designed to target just one specific factor in the clotting cascade. So they are completely overwhelmed by the profound stasis of rheumatic mitral stenosis.
What do you do?
For these patients, you must use the older, heavier-duty anticoagulant, warfarin.
The old school stuff.
Yeah. It broadly suppresses multiple vitamin K-dependent clotting factors all at once.
It's a brilliant example of how you can't just blindly apply modern guidelines without understanding the physical mechanism of the body.
Exactly.
And there's another pathology on the young stroke roster that requires a total paradigm shift. CVT, or cerebral venous thrombosis.
A stroke in the veins.
Right. And the masterclass notes this is tragically common in postpartum women, presenting with worsening headaches and seizures.
And it is entirely different from the ischemic strokes we've discussed so far.
Because it's not the arteries.
Right. We aren't dealing with a blocked artery starving the tissue. We're dealing with a blocked vein.
A blocked exit. And if you scan a patient with CVT, you often see a hemorrhagic venous infarct, meaning there is active, visible bleeding in the brain tissue.
Yep, blood on the scan.
But wait, if the scanner shows active bleeding and the diagnosis is a clot in the vein, putting a blood thinner into a bleeding brain sounds like a lethal error.
It really does. It violates every basic instinct you have when looking at a brain bleed. But again, you have to understand the plumbing.
The plumbing, okay.
The bleeding in CVT is not caused by high-pressure artery bursting. It's caused by extreme venous congestion.
Like a blocked drain?
Exactly. The main drain taking blood out of the brain is clotted shut. The arteries are still pumping blood in, but there's no exit. The pressure builds and builds until the capillaries literally weep blood into the surrounding tissue.
So the blood is just backing up until the system physically overflows.
Exactly. And the only way to stop that hemorrhagic weeping is to unclog the drain.
Oh, wow. So you have to give them the blood thinner.
You absolutely must administer strong anticoagulants like heparin, even when you are staring at blood on the CT scan. The moment the anticoagulant clears the venous clot, the congestion resolves, the pressure drops, and the bleeding stops.
So in CVT, the bleeding is the exact reason you initiate the blood thinner.
It completely flips the logic.
It really does. It flips everything. And speaking of flipping how we view symptoms, the masterclass spends significant time reframing TIA's transient ischemic attacks.
The infamous mini strokes.
Right. We know these as mini strokes. The classic scenario is, someone loses their vision or has a drooping face, but an hour later they are completely fine. The natural human reaction is just this massive sigh of relief.
Oh, for sure. But that sigh of relief is incredibly dangerous.
Because it's not over.
It's far from over. The masterclass emphasizes that a TIA should be viewed as the unstable angina of the brain. The physical deficit may have resolved, meaning the tiny clot dissolved or passed, but the underlying mechanism is still there.
The ruptured, angry plaque in the artery.
Exactly. It's still there and highly volatile.
So the gun is still loaded.
The gun is still loaded. The risk for a full debilitating stroke is heavily front-loaded in the first 48 hours following a TIA.
40?
Yes. You don't schedule a follow-up for next week. You treat it as an active emergency. They require urgent imaging of the brain and the blood vessels, and they typically need dual antiplatelet therapy initiated within 24 hours to stabilize that angry plaque.
Because waiting lists for TIA clinics just result in permanent strokes.
Unfortunately, yes.
Okay, so we've mapped out the strategy for when a pipe is blocked, whether arterial or venous, and how to aggressively clear it. But the ER physiology shifts entirely when that pipe actually snaps open under high pressure.
Yes, it does.
Part 3 of the masterclass focuses on hemorrhages, and the entire medical playbook rewrites itself.
It really does. When dealing with intracerebral hemorrhage, or ICH, we are fighting a very different war. The brain tissue isn't slowly starving.
It's being crushed.
Violently crushed by a rapidly expanding pool of bloody hematoma.
So what's the plan when a bleeder rolls in?
The ER splits into 4 immediate simultaneous jobs. First is blood pressure control.
Which is the opposite of the ischemic stroke, right?
Yeah, exactly. With a blocked pipe, we allow high pressure to push blood to the penumbra. In a burst pipe, high pressure is fuel for the fire. You must smoothly and rapidly lower the systolic blood pressure to around 140 to reduce the hydrostatic pressure pushing blood out of the ruptured artery.
You literally have to turn down the pressure in the whole house to stop the leak.
Perfect analogy. Second is aggressive reversal. If the patient is on any form of blood thinner, you reverse it instantly.
How?
If they're on warfarin, you give IV vitamin K and a specific compound called 4-factor PCC.
PCC. Not just plasma.
No, and that's a key point. You cannot rely on slow IV drips of fresh frozen plasma or FFP. FFP takes too long to thaw, it requires massive fluid volumes that the patient can't handle, and it works way too slowly.
And time is brain.
Exactly. PCC provides concentrated, immediate clotting factors because every single minute of active anticoagulation allows that hematoma to expand and crush more tissue.
Okay, so that's 2. What's the third front?
Third, you manage the overall internal pressure of the skull through head positioning and hyperosmolar medications. Just try and give the brain some room.
So if the pressure is controlled and the thinners are reversed, the only thing left is the physical mass of blood. At what point does a surgeon actually have to go in and open the skull?
That is the fourth front, the surgical alarm. Many deep brain bleeds are managed medically because digging through healthy tissue to reach them causes more harm than good.
That makes sense.
But a bleed in the cerebellum, the lower back of the brain, is a massive exception.
Why the cerebellum?
The anatomical space down there is incredibly tight. If a cerebellar bleed expands over 3 centimeters, there is nowhere for the blood to go except forward.
Forward into what?
Into the brainstem. And it compresses it. The brainstem controls your heart rate and your breathing. If it gets crushed, you die.
Oh, wow.
It is an absolute call the neurosurgeon right now emergency for immediate evacuation.
It is so intense how the specific anatomy dictates the urgency. But the sources outline another type of hemorrhage that presents entirely differently. And honestly, it's terrifying.
Ah, yes, the SAH.
The subarachnoid hemorrhage. This is the condition famous for the thunderclap headache. A headache that doesn't build over hours, but reaches its absolute worst, maximum agony, within seconds to a minute.
Patients often describe it as being struck in the back of the head with a baseball bat.
God, that sounds awful. And the sources provide a case study that highlights how easily this can be missed. A 42-year-old teacher is in the middle of a stressful argument when this explosive headache hits her, accompanied by vomiting.
Classic presentation.
She takes some strong painkillers. It eventually eases to a severe but manageable ache, and so she waits. 2 days later, her family brings her into the casualty ward. The doctor examines her, and her physical exam is flawless.
Flawless.
No paralysis, she's coherent, walking, talking, blood pressure is fine. They do a CT scan at the 52-hour mark, and it comes back completely clear. 0 blood. The doctor writes her up for migraine pills.
And if they send her home, she will likely die within the week.
Right. But okay, look at it from the initial doctor's perspective. If her physical exam is perfectly normal, she's chatting with the nurses, and the modern CT scanner shows absolutely no blood, why would you subject her to a painful lumbar puncture, a spinal tap? Sending her home with migraine pills seems entirely logical based on the data in front of them.
If we connect this to the bigger picture, it seems logical until you understand the specific pathophysiology of a subarachnoid hemorrhage. First of all, a normal physical exam excludes absolutely nothing. Nothing. Patients with a good grade SAH walk and talk perfectly fine because the aneurysm has simply leaked blood into the fluid space around the brain. It hasn't necessarily destroyed localized brain tissue yet to cause paralysis.
Okay, but the CT scan was completely clear.
And this is where understanding the technology's limitations is vital. The CT scan has a very strict timing curve for this specific bleed.
What's the curve?
Within the first 6 hours of the thunderclap headache, a CT is incredibly sensitive, close to 100% at seeing fresh blood in the subarachnoid space. But as time passes, the cerebrospinal fluid circulates, and the blood begins to wash away and degrade. By 24 hours, the scanner's ability to see the blood drops drastically.
So a scan at 52 hours.
A normal CT at 52 hours is functionally useless for ruling out an SAH. It just means the blood is no longer dense enough for the X-rays to catch it.
Wow. The date stamp on the scan completely changes how you interpret the result. So what is the alternative then?
If the story sounds like a thunderclap and the scan is delayed, you must perform a lumbar puncture, a spinal tap. And you aren't looking for fresh red blood cells. You're looking for a phenomenon called xanthochromia.
Xanthochromia. Break that down for me. Why does the spinal tap succeed where the scanner fails?
When red blood cells sit in the spinal fluid, they eventually break down. One of the breakdown products is bilirubin, which is a bright yellow pigment.
Like with jaundice.
Exactly like jaundice. So the spinal fluid, which should look like clear water, turns yellow. This is xanthochromia. And the crucial mechanism here is that while whole blood washes away from the CT scanner's view in a day, that yellow bilirubin pigment persists in the spinal fluid for up to 2 weeks.
Up to 2 weeks? That is incredible. The bilirubin just doesn't care that the CT scanner missed the window.
Exactly. And because a sharper clinician realized this, they performed the spinal tap at 54 hours. The fluid was yellow. They found what the masterclass calls her sentinel bleed.
A sentinel bleed? What's that?
It is the warning leak. It's the aneurysm groaning and giving way slightly before it suffers a catastrophic, complete rupture. Because they listened to her description of how fast the headache peaked, the thunderclap, and pursued the spinal tap, they did a CT angiogram, found a 6mm aneurysm, and coiled it the next morning.
Wow.
They secured the structural weakness before it could blow.
The masterclass states that taking the thunderclap history literally is the cheapest aneurysm clip in medicine.
It truly is.
But surviving the coiling isn't the end of the war, is it?
Yeah.
The sources outline a pretty grueling second week for these patients.
Yes. The physiological fallout from having raw blood irritating the surface of the brain is immense. Between days 4 and 14, the blood vessels reacting to that toxic blood breakdown can go into severe spasm.
Vasospasm.
Right. And it narrows the pipe so drastically that it can cause a massive secondary stroke, which we call delayed cerebral ischemia. To combat this, every single SAH patient must be put on a calcium channel blocker called nimodipine for exactly 21 days. It prevents the smooth muscle in the vessels from clamping down.
And there's fascinating fluid dynamic here too, right? If they develop salt wasting, where their sodium levels crash,
Yeah.
you never restrict their fluids.
Never restrict fluids. If a patient has vasospasm, their pipes are dangerously narrow. The only way blood is getting through those narrowed pipes is by maintaining a high volume and high pressure.
Oh, I see.
If you dehydrate a brain that has vasospasm, you lose all perfusion pressure. The sluggish flow stops completely, and the brain simply infarcts. You have to pump them full of volumes and salt to keep the pressure up and force blood through the spasms.
So what does this all mean for you, the listener? Whether you are a medical student prepping for rounds, a professional updating your knowledge, or just someone who wants to know how to protect your family.
It's crucial for everyone.
It means that time is brain is a literal countdown of 1.9 million neurons a minute. It means that if someone experiences a mini stroke that gets better in an hour, you do not cancel the doctor's appointment.
No, you speed to the emergency room.
Because the risk of the real thing is heavily front-loaded. It means if someone describes a headache that hit its absolute worst within seconds, that thunderclap history outranks any normal physical exam or delayed CT scan.
Don't let them send you home with migraine pills.
Exactly. And it means if you or loved one are ever discharged after a stroke, you demand to know the exact mechanism. You don't settle for hypertensive stroke. You find the box so you get the exact right prevention.
The overarching theme here is that survival requires us to think mechanistically. The parallel pipelines, the specific imaging protocols, the targeted reversals, they are all brilliantly engineered to save tissue.
Right.
But they rely on the patient actually getting to the door in time, and they rely on clinicians fiercely questioning what the standard tests are actually saying.
It requires critical thinking at literally every step. And that leaves me with one final provocative thought to kind of mull over.
Let's hear it.
We've talked extensively about how time dictates everything, but modern imaging is starting to challenge the tyranny of the clock. We now have MRI techniques, like the DWI flare mismatch, which can actually show doctors the difference between the dead core and the starving penumbra in real time.
It's revolutionary.
We are beginning to treat strokes based on the actual biological state of the tissue, rather than just the clock on the wall. This is already saving people who wake up with a stroke and have no idea when it started.
The wake-up strokes, yes.
But if we can map the exact state of the penumbra, how long will it be until continuous wearable technology paired with AI can detect the exact microscopic change in cerebral blood flow while we sleep?
Oh, wow.
Imagine completely eliminating the unknown clock of a wake-up stroke. The ambulance could be dispatched before the penumbra even begins to starve.
When you ground yourself in the reality that 1.9 million neurons are lost every minute, any technology that can intercept that timeline isn't just a medical convenience, it represents a profound preservation of human identity.
A preservation of who we are. Thank you for taking this deep dive with us today. Remember, the math is terrifying, but the medicine and the detective work behind it is catching up fast. Stay curious, stay informed, and we'll see you on the next deep dive.
That completes the Stroke Master course. If you found this masterclass useful, consider subscribing to Clinical Horizon for more evidence-based internal medicine teaching, clinical cases, and exam-oriented reviews. Thank you for listening.